Okay, I'm going to make a start. So first of all, I want to say a huge welcome to everyone who's joined us for this Health Inequalities webinar this afternoon. I'm Saffron Caudry. I'm Deputy Chief Executive at NHS Providers, and I'm going to be chairing today's event. First thing to note, this event is being recorded. So if you don't want to participate in a recorded event, then please step away now. But we record it so that people have access to this if they weren't able to attend today, and so people can also refer back. For those of you who don't know, NHS Providers is the membership organisation for trusts and foundation trusts, helping all of our members, and we have 100% in membership, to deliver high quality patient focused care by enabling them to learn from each other. We act as public voice of trusts across the country, and we help to shape the system in which trusts operate. Our Health Inequalities programme is a support programme which helps support members to make sense of health inequalities and embed it as part of core business. And the resources that we produce are informed by our research and engagement with trust leaders, which has taken place over the past year. In today's session, we are focusing on anchor institutions and how they can help tackle health inequalities. And anchor institutions are really well placed to support local community health and well-being, tackling health inequalities. And as we have been developing our work around health inequalities, the anchor institution agenda has been noted by many trusts as being a real underpinning principle for their work on reducing health inequality. So what's the role of the organisation itself and the framework for trusts to look to influence population health in their local area and beyond, in terms of the healthcare services that they provide? So you have the slide here with the agenda. We've got three really great speakers today. In terms of what we're going to cover, we're going to look at partnerships, supporting healthy places, widening access to good employment, and contracting for local benefit and social value. And today's speakers are, in order of presentation, Lucy Gardner, who is Director of Strategy and Partnership at Warrington and Halton Teaching Hospitals NHS Foundation Trust; Shell Stanley, who is Head of Leeds One Workforce Programme at the Leeds Health and Care Academy; and last but not at all least, Angela Bartley, who's a consultant in public health and Director of Population Health, and Kate Dunn-Campbell, who's Population Health Specialist Registrar at East London NHS Foundation Trust. So if possible, once the presentations are done, if we can ask you to keep your camera on, it just makes a better interactive environment for the webinar. I've said before that the session is being recorded. We will come to questions after each speaker has spoken, so please keep your microphone muted during the presentation to cut out any background noise, and do feel free to use the chat box to share thoughts, ideas that come to you, and to ask any questions. If you want to ask a spoken question, then please do raise your hand, wave at me, however you want to get in contact with me, and I will come to you. And we do commit that any questions that we can't answer at the time, or we don't get time to do, we will come back to you with an answer after the session has finished. And critically and importantly, we will send you an evaluation form, and it helps us enormously if you will fill that in and let us know what you thought of the session, because we genuinely act on the feedback and we improve our offer to you by taking on board the comments that you've given us. So without any further ado, I am now going to pass us over to our first speaker, who is Lucy Gardner. She's going to talk to us about partnerships to support healthy places. She's probably going to talk for about 10 minutes or so, and then we'll have 10 minutes of conversation and questions. So over to you, Lucy.
Thank you, Saffron, for the introduction. As Saffron said, hi, my name's Lucy, and I'm Director of Strategy and Partnerships at Warrington and Halton Hospitals. Could I have the next slide, please, Amelia? I should say apologies for my slightly croaky voice. Hopefully I'll make it through. I'm just recovering from the flu. So I'm just going to start by saying a little bit about Warrington and Halton for those of you who are not familiar with our places. We sit within the Cheshire and Merseyside ICS, and as you can see on the slide, we have a really high level of deprivation, in particular in Halton. We also have very significant health inequality. So interestingly, in both of our boroughs, there is a 10-year gap in life expectancy within borough. And as you can see, Halton is really low in terms of the index of multiple deprivation when compared to other local authority areas nationally. We also have, I think, what is a common challenge nationally in terms of a significant forecast rise in over 65 people within the population over the next 20 years. Altogether, we serve a population of about 330,000 people across Warrington and Halton. Could I have the next slide, please? Thank you. So I just wanted to pull out a few of the statistics in terms of our challenges around health inequalities, and I'm not going to go through everything on this slide, but just to pull out some of the, I think, quite shocking facts about our population in Halton. So babies within the first 14 days of their life are 46% more likely to be readmitted to hospital than they are elsewhere within the country. Our teenagers are 90% more likely to be admitted to hospital for alcohol-related reasons, and our adults 90% more likely to be admitted to hospital for violent-related reasons. And in older age, we have 47% more likely to die from a cause that is considered preventable. So you can see some really stark challenges in the populations that we serve. Could I have the next slide, please, Amelia? Thank you. So we are very conscious of our role and responsibility as an anchor institution, and have in fact made it a core objective within our trust strategy. Conscious that anchor can be sometimes a little bit difficult to explain to the public and to, you know, our wider staff group. So we've tried to break it down into these three areas in terms of delivering social value, our green agenda, and health inequalities, which is obviously the focus of today, albeit that they are all interrelated. So I wasn't intending to go through this slide in detail, but the slides will be shared after the presentations today. Can I have the next slide, please, Amelia? Thank you. So our anchor programme is quite broad, and today I'm going to focus on one specific area in terms of where we work really closely with other partners to deliver care within the community. But I just thought I'd share a few other examples just to kind of give a sense of some of the depth of our anchor programme itself. So the first one here is an example of us working with our local authority, and we've just recently introduced wellbeing advisors into some of our key wards within the hospital to aid with discharge, really. On the first day that our wellbeing advisor was supporting the ward, we had a really good example of the importance of their role. So we had a really complex discharge of a homeless patient, which I think typically that homeless patient probably would have stayed in a bed within the hospital for significantly longer than one day normally, whilst we, I guess, struggled with the challenge of how we could support them back to a place of safety. And the wellbeing advisor was able to support us to do that really quickly, both in terms of securing a short-term placement for 2 days, and then a long-term placement in terms of somewhere for that person to live. So just the impact of that and working in partnership with the local authority was huge, and that's something that we've continued following an initial pilot. There's a couple more examples of working with our education partners, so working with a local college to provide internship programme and employment opportunities for students with disabilities, which again has had really positive outcomes. And then just an example around our Smart Heart programme, which involves one of our consultants, Ahmed, visiting school children to help educate them in terms of looking after their hearts. And some of the feedback that we've had is the impact that that actually has had on their parents. So interestingly, their parents are much more likely to listen to their children in terms of stopping smoking, for example, than they potentially are healthcare professionals. So we're already seeing success in terms of the impact on parents, and hopefully we'll see that success as the children themselves grow up. So they're just a few examples of some of the smaller things that we're doing as part of our Anchor programme. Could I have the next slide, please? Thank you. But what I wanted to focus on today really was some of the work that we're doing around providing integrated care within the community delivered by multiple partners that is really aimed at the specific health inequalities within each area that these hubs are or will be based. And some of this is included in our case study, which is on the NHS providers website. So we're in the process of developing 3 hubs across Warrington and Halton. The first one that I was going to mention is just summarised on this slide. So this is so we call this a Warrington Living Well Hub. It's due to open this summer/autumn. And here what we're doing is we are providing services that are based around some of the immediate challenges and the significant health inequalities in the centre of Warrington. So we know that our population in the centre of Warrington, they have the poorest outcomes within the borough and are expected to live 10 years less than those in other parts of the borough. And their specific challenges include things like mental health and well-being, but also particularly poor outcomes around some of our children and family outcome measures, and also those in our population who we might call pre-frail. So for example, we have a disproportionate number of people admitted to hospital due to falls compared to other areas within the country, and also some real challenges around I guess kind of memory loss in kind of older age adults. So kind of both physical and mental health support, more targeted at prevention prior to those individuals becoming iller and requiring more acute care. So in terms of the provision that's planned for our Living Well Hub, in terms of statutory providers that will be providing care and services from the hub, it includes ourselves as the Acute Hospital Trust, also our Community Healthcare Trust, our Mental Healthcare Trust, our local authority and GPs, as well as a number of providers from the community sector and also voluntary sector. You can see some of the planned benefits that are set out there. And as we've kind of evolved the model of care, we've also taken a lot of feedback from not just members of the public, but also local organisations and those that represent the public and patients. And for example, have really tailored services that have been added in. So we're going to have an evening that will be dedicated to care leavers, as we know that care leavers have particular challenges within our borough, both in terms of being able to gain peer support and professional support, and even quite simple things like being able to wash their clothes. We've included a washing machine, for example, and shower facilities. So really exciting, not open yet, a lot of work to do. We did in fact just write to Alan Titchmarsh today to see if he could perhaps do the garden that we're planning to have on the rooftop. Sadly, we got a no, so any volunteers who are good at gardening, you're very welcome in Warrington and Halton to help us with that. This project was kick-started by some funding by the National Town Deal Programme, which you'll see is also the source of funding for the next one. The Town Deal Programme is a national programme that was targeted at 101 towns nationally, essentially a levelling up programme, but not focused on health, interestingly. So focused more around education, employment and economic outcome measures. But fortunately, we've been really supported by our councils to include health elements because there's a recognition that actually, you know, we can't improve necessarily education and employment outcomes without improving health. So we're still working through the recurrent revenue costs because we'll need to share them as providers within the hub. Could Could I have the next slide, please, Amelia? Thank you. There's just some visuals of kind of what the hub will look like. So you can see some floor plans. There's 3 floors to this, so it intends to be kind of a really informal, welcoming space on the ground floor, with some more kind of clinical rooms and group support rooms on the 2nd floor, and then staff facilities and a garden that all will have access to, including visitors to the hub, on the top floor. And it's in the very centre of Warrington town centre, adjacent to the bus stop. Can I have the next slide, please, Amelia? Thank you. So the second one that I wanted to talk to you about is really similar in terms of how it was originally developed, which is a health and education hub within Runcorn, which is part of Halton. So you can see some of the details there in terms of space. I think what's important is that the services are targeted at a slightly different group of people within the community, and that's because we have different challenges in Warrington to those that we have in Runcorn. One of the key differences is because Runcorn has quite an industrial past. We have particular challenges around long-term conditions, and particularly respiratory long-term conditions, and also kind of sexual health challenges for young people, as well as access to employment being a challenge. So one of the key differences is that within this hub, we will also be providing education services via the local college, and particularly target as well at employment within the health and care sector and access to employment. So a very similar premise in terms of how it was developed. You can see some of the benefits plan on the right-hand side of the slide, and similar in terms of funding arrangements. So Runcorn was in the 3rd wave of the Town Deal programme, whereas Warrington was in the 1st. So we've got a slightly later opening date for this one, and it's forecast to open in spring of 2025. Can I have the next slide, please, Amelia? Thank you. And there's just some visuals of the plan for the Runcorn Health and Education Hub. So similar premise in terms of being relatively informal as you come in, and then moving into the back of the building, more formal kind of clinical rooms and areas where private and confidential conversations can be held. And then if you just, I've just got a little note to say, can I round up, which I will do really quickly. And so excitingly, our 3rd one and final one that I was going to talk about, we have already opened, which is very exciting, which is a health hub within Runcorn Shopping City, which is a shopping centre that was at risk of closure. As we'll know, there's been a demise of town centres lately, and it started out as us providing ophthalmology, audiology and dietetics outpatients. We have since expanded that. We opened in November, and since opening we've expanded to provide vaccinations via the public health team, primary care respiratory services, and we've got GP enhanced access, including GP appointments on Saturdays, opening very shortly. The funding arrangement for this is very different, and we've contributed significant funding as an organisation, which you can imagine is challenging from an acute health care trust perspective, but also received some funding via the Liverpool City region. And there's a few pictures on the next 2 slides. Amelia, if you wouldn't mind just flicking through those, that's great. And there's one final slide. So it has been incredibly challenging to date, and you can see some of the challenges that we've experienced there on the left-hand side, but also the impact of these hubs. So I think, as it says on top of the slide, the challenges are worth it already in terms of the one that we've opened, but will continue to be worth it. And then the final slide, thanks Amelia, is just a thank you to our many partners without whom this wouldn't be possible, and lots more to come. Thank you. Happy to take any questions.
That was really fascinating, Lucy, and thank you so much for that. We've already got some questions in the chat, which is great. So first question we've had is from Tal Rosenzweig, who asks, are the wellbeing advisors employees of the trust, or is it done in collaboration with voluntary and community sector? And was the model co-developed with people and communities?
Thanks, Saffron. So in the example around the Warrington Hospital site, which is the example on the side, the wellbeing workers are employed by the council, by the local authority, and there's no intention really to change that. What we are looking to do is expand that model. So we're also working with the local authority and the voluntary sector to expand wellbeing advisors, which is being done in partnership, very much in partnership and co-created with our local community. So it's probably fair to say that the pilot wasn't. They were existing wellbeing advisors employed by the council who we thought, well, we'll try out basing them in the hospital, which did work really well. But going forwards, the expansion is very much community led and will be provided by the local authority and the voluntary sector.
Thank you so much for that. I'm going to come to Lizzie to ask her question, then we'll come to the next question on the chat after that. Lizzie, over to you. Do you want to say where you're from?
Thanks. I'm a non-executive director at the Great Western Hospitals NHS Foundation Trust. And you may have not made reference to this specifically, but I'm assuming with the hubs, because they look like really exciting places located right in the heart of the community, that one of the added benefits, surely, and so this isn't so much a question as an observation, is the opportunity to engage with the community, for people, I don't know, it to be a public space. So when you're saying you're working in partnership with the community and voluntary sector, is there any space that can be used for those organisations? Because I think that's one of a really powerful way of supporting local communities, is to provide them with some space.
Thanks, Lizzie. It's a great question, and absolutely we agree that that's really important. So yes, yes is the short answer. There's a really good example in the Runcorn Health and Education Hub, where we've got a space that is essentially, we kind of try not to call it the gym because that gives an idea that it's got all loads of gym equipment and stuff, which hasn't. But it's got, you know, it's got the type of flooring that means it could be used for anything. So it could be a group space that any kind of I guess voluntary sector organisations can use for any groups or services or opportunities for people to come together that they would like to. And we also have some group rooms within both of the Health and Education Hub and the Wellbeing, the Living Well Hub within Warrington, that are slightly, I guess, slightly more formal group spaces, do you know, where there's opportunity to do group training or group counselling or whatever it might be. So absolutely, that's a core part of the plans. And equally, when we're looking at kind of ongoing revenue costs, the intention and kind of what we've all signed up to for now is that all of the statutory provider organisations will share those revenue costs, so that there isn't an expectation on the voluntary sector to contribute financially.
Okay, I'm going to see if we can get through a couple more questions before we finish on this section. So we've got a question from Natalie Vanderpant, who asks, this is really interesting work showing analysis into action, which I think is one of the things that comes through a lot actually in health inequalities work, which is what does the data show us, and then what do we need to do about this? And then Natalie goes on to ask, is this being led by the trust or the ICS?
Thanks, Natalie. So in each of these three examples, they are being led by the trust. It's interesting because from a town deal perspective, I represent health as a whole locally on those town deal boards. So actually, I would say I'm acting on behalf of health providers rather than necessarily just the trust I'm employed by. But we have now started to report into place and into the ICB as they've evolved.
Excellent. And I think that's kind of a sign of the times, isn't it? The different hats that you're actually wearing, and particularly that collective kind of representation role for a function rather than a specific institution. We've also got a comment here from Wayne Daly, who talks about the work that he's been doing, or that they've been doing in their shopping centre in Cramlington, which it's become really successful community hub, library and wellbeing centre. And I think we are seeing that expansion across the piece of those approaches. I'm just going to ask you one more question before we close on this, which is really thinking about how do you think you've brought about that kind of cultural shift and the change in strategic emphasis that's needed to make the best use of the trust role as an anchor institution, as an anchor within your community? How has that kind of come about?
It's a great question. It's really challenging, that, isn't it? So,
Yeah.
so I think there's the two angles, isn't there? There's how's that with partners and how's that within the trust itself. So I feel really fortunate in that our chief exec is really passionate about working in partnership and about our role, not just in terms of providing good acute care, but about our role in terms of the wider community and the wider determinants of health. So I feel really lucky on that basis, which kind of gives me the freedom to work more closely with partners on things that might not have previously been seen as core business for hospitals. And then it's through those relationships, I think, that's enabled us to change that culture within place and with partners, so that we're no longer just viewed as being interested in hospital care, but in the broader health outcomes. So it's probably those two things. And actually, I think what's been really important is that other providers then have also been supportive of us, for example, leading a project on their behalf, which is quite a big change as well, in terms of the other healthcare providers locally. But that seems to be working well at the moment.
Thank you. Thank you. And I think, you know, that's going to be something that many organisations will be grappling with as they go through their anchor journey. Hate using the journey word, but I think it is one. I think I'm really struck in listening to a lot of what you're talking about, which is that tackling health inequalities is really a job around prevention as well, isn't it? It's not just a job around, not just that equity is absolutely critical, but a key part of that is prevention. And that's certainly one of the things I take away from your presentation. It'd be really great if people could reflect their own views of what's the one thing they would take away from what Lucy has talked about today, and put those in the chat. It really helps us to gather that kind of learning and impressions from each of the presentations. Thank you so much for that, Lucy. We may well come back to you in the final round of questions when we go into plenary session, but thank you so much for that presentation and for so ably answering the questions. So now I'm going to move on to our second presenter, the second session in this webinar, and we're going to come to Shell Stanley, who's going to talk to us about widening access to good employment and the work that she's doing at the Leeds Health and Care Academy. So over to you, Shell. Really look forward to hearing from you.
Thank you. So just a bit of context before we start. So workforce across health and care remains the biggest key risk around sustainable service delivery. And the Leeds Healthcare Academy and One Workforce exists to support health and care systems work together to deliver shared workforce priorities. So I'm here to talk about a partnership approach across all our statutory organisations, including independent, voluntary, third sector partners within Leeds. Next slide, please, Amelia. Thank you. So there's been a long recognition in Leeds that health and care systems will only work effectively for the population we serve through supported infrastructures, practices, and a workforce which is motivated and enabled to work across organisational boundaries. So this work is primarily planned and coordinated through the Leeds Health and Care Academy through collaborative workforce planning and analysis, shared learning and education, and collaborative workforce projects. These collaborative strategic approaches enables partners to drive forward the shared strategic workforce priorities in an increasing integrated way, with the ambition to optimise investment and resource, focus expertise, coordinate activity, and ensure benefits are realised for the whole health and care system. Next slide, please. So within Leeds, there's an ambition that we will be a healthy and caring city for all ages, where the poorest improve their health the fastest, with a commitment to work together to provide opportunities for skills, jobs and wealth creation, engaging and recruiting those from our most disadvantaged areas, inspiring the next generation of health and care workforce. Through this collaborative approach, we know that we will be able to ensure a highly diverse, skilled workforce, which is needed for now, but also in the future. And we recognise that there's an uptick in terms of quality of care delivery and patient experience when the workforce reflects the communities in which we serve. Next slide, please. So our partnership approach to narrowing inequalities is through ensuring good employment and widening participation, and that's what I'm going to talk to you about over the next couple of minutes. So our approach was co-designed with communities of interest. So everything that we've done to date has been through a geographically targeted approach, focusing on our most deprived areas. These are the 3% most deprived neighbourhoods within the city, with particular interest and focus on the priority neighbourhoods within those wards. So we kind of collectively mapped out who the opportunities were for, who we wanted to engage with, and what career opportunities were potentially available for these people. Next slide, please, Amelia. And then we thought about the model of delivery. So the model of delivery for the work I'm going to showcase was through a hub and spoke model. And the hub and spoke model allowed a continuous flow of data. So candidates were referred in, either independently referred in or referred in through third sector or community-based organisations who were already working with candidates. And through the hub, people were given bespoke support based on both their ability and their ambition, and they were mapped onto a spoke of activity, whether that was education or training, a pre-employment programme or direct employment. Because when we look into local communities and we work with targeted hyperlocal recruitment, there is always hidden talent within those communities. So what we were able to do was identify hidden talents and fast track them into opportunities. Next slide, please, Amelia. So just reflecting back on to the slide that identified who we were looking to reach. So you can see the work we've done today in terms of candidate age, they tend to be around the 16 to 25, with a large portion being 35 to 44 years old. In terms of looking at diversity data, you can see the ethnicity of candidates that we've supported through this process. The hub and spoke model I've just described is very, very diverse, with over 40% being from a BAME background. And again, thinking about health inequalities and recognising that health inequalities, good employment leads to better health, you can see the majority of people that we've supported through this process were unemployed. But interestingly, a number of people who identified themselves as being employed were actually on 0-hour contracts. And we know that secure employment, good employment, comes with a secure contract rather than 0-hour contracts. Next slide, please. So the opportunities that we had available, we were quite ambitious, thinking we were going for volunteering, training, education, experience roles and entry-level roles. And actually what we found was the majority of people we supported into employment were through an entry-level role. However, each of the entry-level roles sat within a career pathway, and we've got a number of case studies that I'll make available to you that demonstrates how people have got on and gone further through the support processes we have in place. Next slide, please, Amelia. So what careers did we think would be available when we set out to do this piece of work 12 months ago? So we had kind of 5 different departments that we were looking to explore. And you can see there we've got 8 or 9 job opportunities or job roles that we've secured through this piece of work. Next slide, please, Amelia. And those employment opportunities were across 5 different organisations. So we've got obviously the NHS organisations, we've got a third sector organisation, and we've got one of our HEI providers. Next slide, please. So I want to talk about the success and impact of this piece of work, connecting communities. And I want to look at 3 different lenses. So to start with, I want to look at community engagement. So through the hub and spoke model, in the last 12 months, we've received 850 expressions of interest. And as I said, they were directly made by the candidate themselves or through a third sector organisation or a community network. Of the 850, can we go back please, Amelia? Thank you. Of the 850 expressions of interest, 700 candidates resided in one of the 6 priority wards within the city. We've supported 211 people into education, training or employment. That doesn't mean that we've lost the other 500 people, it means they're currently mapped onto a spoke of activity, whether that's volunteering or work experience. I've identified as a measure of success here 17 COVID vaccinations were administered through this programme. And the reason I mention this is because, 2 years after the COVID pandemic, 17 vaccinations were successfully administered in the local community through partnership working with Bevan nurses, 3 of which were first vaccinations. And through engaging with communities, the most powerful method for engaging was through word of mouth. So we did the traditional leaflet drops, we connected in with networks, we went to schools, we went to kind of local estates within the community to kind of spread the opportunities that we had available. But what was most powerful was word of mouth. Next slide, Amelia. So the second lens I want to look at in terms of success and impact is through recruitment. So over the last 12 months, we've supported 123 people into work. We actually offered 130 conditional offers, but people haven't progressed. They've decided to opt out of going through the onboarding process. I've mentioned that we've established fast track processes within organisations across the health and care system to support hidden talents. So if someone was qualified in a different country, for example, we've established processes through working in partnerships to fast track them into employment. So cutting out NHS jobs, cutting out kind of track or any kind of process and flipping the recruitment model to speed up the process. 90% of those supported through a pre-employment programme went on to receive a conditional offer of employment. And again, 90% is a good measure and it's a measure of success. However, it doesn't capture people who actively stepped off a pre-employment programme. So through a flipped recruitment process, and that's training up front, so coming in through the hub through an expression of interest, mapping someone onto a pre-employment programme, training people up front, then giving them interview questions prior to interviewing them, and then moving them forward to onboarding. So completely flipping what we consider a traditional recruitment method was really, really successful because it enabled people to undertake associated activities in a simulated setting. And what it didn't do is we talk about holistic care, we talk about person-centred care, don't we, in our professional lives, but our traditional recruitment methods don't enable us to look at people holistically because we shortlist against someone's ability to write a job description, whereas the flipped recruitment model allows us to see someone in a holistic sense over a period of a week or 4 weeks, depending on what spoke of activity they're undertaking. And what that does is enables us to see that whole person and the value add they can bring. So when it comes to interview, the interview isn't a yes or no, which is why we give the interview questions up front. Because we've built up quite an evidence base now in terms of success stories and case studies, we're actually finding that partners are adapting their recruitment processes across the health and care system in Leeds to revert to a values-based recruitment, which widens participation. Next slide, please. And the final lens I'd like to look at is retention and development. So alongside the 130 conditional offers of employment we've made, 131 people have achieved an accredited qualification through this hub and spoke model, and 100% of those supported into employment remained employed after 10 months. And we've actually got the figures back as of yesterday, which says from 12 months employment, we've achieved a 95% retention rate. So part of our offer in terms of building up that evidence base to change systemic changes in terms of inclusive recruitment is we map candidates at 3, 6, 9, 12 and 18 months once they go through the supported process. And we offer additional support through a peer mentoring offer, which is Start Your Journey Leads, which we believe has helped with retention. Next slide, please. There is the case studies, as I said, that can be identified on the Leeds Healthcare Academy website. What I want to just mention is the work I've just described to you, although very brief, was completely unfunded. So we have no external funding to deliver this piece of work. The piece of work has been delivered in partnership within people's day jobs. So we've had no additional funds to achieve what we've achieved. However, because we are building up case studies, We are now attracting external funding in to accelerate and amplify the work that we've started. You can stop sharing, Amelia, thank you.
Thank you so much, Shell. That was really, really interesting to hear. So we're getting these different perspectives coming through. Obviously, we had the kind of the very, you know, sitting in the community, the hub approach that we had from the first presentation, and now we've got this sense of what it means to be an anchor institution in terms of employment and supporting someone's health and well-being and tackling health inequalities through employment. We are open for questions now if anyone wants to ask a question. We've got one here in the chat which we'll start off with, but please do feel free to wave at me or put a question in the chat if you want to ask one. So Alan Dawson has asked, can you tell us a bit more about how the flipped recruitment process works? And this does sound fascinating and kind of a unique element of what you're doing. So perhaps if you could give us a bit more detail on that, that would be great.
Yeah, and what I will do is send a graphic round that we've developed to demonstrate the flipped recruitment model. So as I mentioned, NHS jobs, for example, someone applies for a job, they write their skill set against a job description, and then we shortlist against someone's ability to write against a written word. The flipped recruitment model is where we take people based on their values and their ambitions, and we screen them for eligibility, and we put them through a pre-employment programme or some training programme so they can undertake associated simulated activity associated with that job role. So for example, we have a careers in care programme of work where people within a classroom setting will undertake healthcare related tasks, including moving and handling, dementia training, hygiene, washing, feeding, and they will do that hands-on care, but in a classroom setting. So it's, you know, quite safe, enabling people to undertake associated roles in advance of going through a process, gives them the opportunity to make an informed decision whether that role is right for them. And it also allows the provider, the training provider, to view that person holistically. So looking at the values in much greater detail than a 15-30-minute interview can do. So for example, we measure people against a number of domains. Do they turn up on time? Are they good, good communicators? Are they team? Do they work well in a team, etc.? And what that does is it gives us a character reference to support onboarding. So if people are going to turn up for training, demonstrate a willingness to learn, demonstrate all the right values that align to Leadsway values, the interview isn't a yes or no, the interview is part of a formal process. So the interview questions are given up front, the candidate is interviewed, and then the character reference that we've collected over that period of time supports the onboarding process. Because if you think about what we're actually doing through our targeted approach to hyperlocal recruitment, some of our communities or candidates within our communities haven't worked for a period of time. So that then kind of delays onboarding. And what we've got is an evidence bank now that suggests that the flipped recruitment model saves time to hire costs, associated costs with managers' time to shortlist and recruit, because the candidate has already been pre-screened. It sits outside of the organisation. And what we've got evidence of is that we can actually reduce the traditional recruitment cycle by 6 weeks.
That's really, really helpful and full answer, and I hope that kind of adds to your knowledge and understanding of that process. A couple more questions coming in here. I'm going to take them together actually. So Wayne has asked, do you still require a certain level of qualification, I'm assuming, to access the programme? And then Morven Smith has asked, can you outline what level of post-employment support is provided if different to other routes to employment, and how this is provided to help with retention? So how do you access, and then what happens once people are in employment?
So through the hub, people are screened. So they undertake a BKSB, so that's a basic maths and English test, and we ascertain the level in which they're working at. And the entry level 3 is kind of the minimum to progress onto a pre-employment programme, and that's the equivalent of around I think it's around a GCSE, old terms, I'm not quite sure what it is, in the new numerical GCSE grading system. If they're not quite there, so if they don't achieve that on the BKSB test, they've moved on to functional skills support or even ESOL support, and then they loop back round. And that's the beauty of the hub and spoke model, that constant data flow, so we don't lose candidates. So entry level 3 is the minimum that we ask people to be working at before we move them on to a pre-employment programme or a spoke of activity. With regards to post-employment support, so the Academy offer peer mentorship. So they offer a programme of work, and again, I can send some resource out to share post-webinar around peer mentorship, health and wellbeing, and shadowing opportunities. So again, we're really keen that people who join the Leeds healthcare system understand our ambition to work in an integrated way, so thinking beyond organisational boundaries.
Thank you. That's really helpful. And I think, you know, we all know from our different settings, don't we, that it's one thing to recruit people, it's another to retain them in role and keep them with the agenda, quite literally. Got a question here, and I was particularly struck by the fact that you said that there was no funding that originally came with this, and someone has just asked about the level of staffing. So how many members of staff within the anchors have worked on the programme to get it up and running, and has there been a full-time team? So that came from Jane Martin.
So project management support has come from the Academy, and then we've had a nominated person from each of our anchor organisations to either sit on an operational group or a steering group, depending on their position. And it's probably equivalent of half a day a week for the last 9 months. And then once we've established programmes of work, they run, sounds really flippant, but they run themselves, they're less resource intensive. And I think what we do well and what we've got evidence of is that constant horizon scanning, so that constant PDSA cycle after each cohort starts. So what 1% improvement can we make? What can we tweak to drive efficiencies? So we purposely didn't go for funding when we set this piece of work up, because we want to make the systemic sustainable changes to narrow inequalities. What we didn't want to do is have a project that was funded that then stopped, because when you engage with local communities, it's through credibility and trust that you get that kind of engagement. And if it was funded and then it kind of stopped or paused, you lose all that, and that's not what we wanted to do.
Thank you. And that, in a sense, speaks to the power of getting the different questions in from those on the webinar, because that really important element about you wanting to make the systemic change yourself, so that you could see what needed to be done and then sustain it and maintain that trust, feels really important. And I think if I have one takeaway from this, it is that, and the holistic approach. And I would, of course, ask you all now, after this speaker, to put your what's your one takeaway from Shell's presentation on this. And I think that's been incredibly helpful and insightful and informative in terms of what you've been doing around this employment initiative. Thank you so much. I'm going to move us on to the next speaker now, so that we don't lose our momentum. And this is a third and different approach, really, to the whole anchor concept, and we're going to be looking at contracting for local benefit and social value. And we're going to be hearing from Angela Bartley, who, as I said earlier, is the consultant in public health and director of population health. Unfortunately, Kate Dunn-Campbell isn't joining us today, so it's just Angela. So over to you, Angela.
Thank you, Saffron. I hope you can all hear me okay. Hi, everybody. As Saffron said, I'm a public health consultant, but I'm based in East London NHS Foundation Trust. So we are quite a large community and mental health trust, and we also run primary care services. We work in East London, so Newham, Tower Hamlets, City and Hackney, and then also in Luton and Bedfordshire as well. So quite a wide geographical spread. We've covered 2 integrated care systems, and we have around 6,800 staff. So a bit like Lucy was saying at the beginning, beginning, we cover a really diverse population. So some of the highest overcrowding areas in the UK and some of the most diverse communities, as well as real areas of deprivation, and also rural health issues as well. So it's quite a complex population to manage. We also hold multi-million-pound contracts. So today I'm going to focus particularly on how we've tried to use our anchor approach and tried to use our contracting to improve the health of the population. So one of the reasons, next slide please, Amelia, one of the reasons I was brought in, next slide, sorry, one of the reasons I was brought in was to really try and help the trust to think from a public health perspective about what more it could be doing, on top of, you know, as both Lucy and Michelle was saying, you know, to build on more than just providing excellent healthcare. It's what else can you do to improve the health of the population, the health of your staff, and the health of the service users as well. So we you know, embraced being an anchor organisation and looked at how we could apply that to our sort of business as usual, our kind of community and our delivery, rather than it being a kind of separate small project that was done on the side. Next slide, please. So we adopted some of the sort of health foundations for aspects really around anchor work. So the 4 kind of key pillars of the programme. So we wanted to look at widening access to employment for local people, embedding social values in our procurement. So that's what I'm going to focus on today. Improving environmental sustainability, and how do we use our land and buildings to benefit local communities. So they were the 4 areas we agreed as an organisation. And I should say we revised our strategic objectives for the trust, and one of the first ones is around our key role in improving the health of the population. So we set out some targets that the trust would hold itself to account on, as well as safe services, financial viability, how do we improve health? And the work we've done around this links to the work in particular around how do we achieve a healthy standard of living for our populations and our communities. So we're building on some of Michael Marmot's work around the social determinants of health, and we've piloted a partnership with Michael Marmot's team in the Institute of Health Equity to look at being the first NHS organisation to apply those social determinants of health to our delivery of work. Next slide, please. The next one. Great, and the next one. So we, about 18 months ago to 2 years ago, just sort of as we were coming kind of through COVID a little bit, we decided what would it really look like if we really are serious about our kind of work around social determinants, if we're really serious about our work as a anchor organisation, what should we be focusing on? So at ALT, we're really lucky. We have a huge people participation and engagement programme. So we really work with a lot of our service users who have experience of poor mental health. So we worked with them, worked with our local communities and our board of governors, did a lot of work around asking them to set the targets for the trust and what we should be doing to try and really focus on the areas they thought was really important. So we looked at those 4 pillars of being an anchor organisation, and the one around social values, and these were the things that they said they wanted the trust to prioritise on. So making sure all of our suppliers pay the real living wage as a minimum. How do we get our spend in local economies? How do we support local businesses and organisations to grow and flourish in our area? Training and opportunity for predicted characteristics for service users hardest hit by the COVID pandemic. So in particular, we focused on some of our Black and minority ethnic communities, on service users for our mental health services, and on people who carers and people who've experienced living in care and leaving care. Next slide. So what do we do around procurement? So we've increased the weighting in our all our contracts. So the NHS minimum is 10%, so we have 15%, and we're looking to increase that further. So a bigger portion of all our contracts is around how well the contractors score against those social value areas. We did an audit of all of our suppliers, again, those multi-million-pound contracts around who was paying the real living wage. And in 2019, that was only 22%. And we've worked with them over the last few years to increase that to 61%. And we've just gone back out to re-audit them all again to see if that's increased. And we had a contract with for our domestic cleaners and porters with an outside agency. So we had a contract with them, and we weren't really happy with that contract. And it was sort of put in place before we really worked on our anchor work. And in particular, during the COVID pandemic, we realised that the first 2 days of sick leave weren't paid, which was from a public health perspective, appalling if you're asking people to stay at home if they think they've got any symptoms. And yet the poorest people in our staff group weren't paid for those first few days. So in terms of just, never mind, you know, cost of living crisis, just in terms of infection control, that was really poor. So we completely revised the contract with the different supplier. And we, as part of that contract, they were put on NHS terms and conditions and better pay. And it's on average £184 a month take home pay difference for those porters and cleaners, as well as being on much better contracts around sickness, absence, maternity leave, etc., etc. And that's working really well with OCS, our provider. As part of our work with our procurement team, we have social value champions. So these are service users we are working with in training. So they're on all the interviews, they're on all the panels, and they work to make sure that when we're recontracting for anything, that we're kind of focusing on some of those social value areas. And we're working closely with our other kind of system partners on this. Next slide. So we were lucky enough, we applied for Health Foundation funding. They chose 3 areas to do a more deep dive evaluation, and ours was looking at our contracting and procurement work. So we worked with the strategy unit, and they came in independently, and they looked at the big contract with OCS for soft facilities management, and they looked at a really small contract that we had around providing our IT and website systems. And they also talked to our suppliers, both those who've got contracts and people who hadn't got contracts with us. And they also talked to some voluntary and community groups that were beginning to kind of bid for NHS contracts. And these were the areas for improvement. So they wanted a much simpler set of social value priorities. So they found some of the way we explained it, what we tried to get them to do, could be slightly confusing. Consolidation of service user involvement, so much more clear, kind of almost train some of our service users so it was a lot clearer for them if they're involved in the process. A single toolkit, sharing the data and information protocol, and extension of our market activities. Next slide, please. So we held a big event in November. It was not August, it was November. And we pulled everyone together around our anchor work. We had an anchor summit with our contractors, service users, stakeholders, all of those people in the room, went through what we thought we were doing well, areas we could develop, and then workshops to say, set us some more ambitious targets. Let's think differently and more creatively across those 4 areas of anchor work. And we're about to produce our social values and procurement toolkit based on the work funded by the Health Foundation and the work that the strategy units helped us do to try and make it simpler and better for organisations. And this is, I should say, another part of ELFT, we have given out over 1.8 million in grants for work to voluntary and community services. So part of that is about how do we build and retain and support our VCS groups to access NHS funding and to provide services. So they have helped us to develop this work as well, because there's a real danger in this work is that you set such high targets that it's only the multinational companies that could possibly achieve it. So we're trying to build it so that actually there's a different weighting, and that smaller organisations and VCS organisations can also meet some of these social value targets, and we'll support them to do that as well. Next slide. So these are our key summits and key ambitions that were developed around the 4 areas, and in particular for procurement, we're just setting out what those ambitions are. And again, one of them is to increase the value of increase the percentage of social value in all of our contracts. Go back out to re-audit. We aim for 100% of our suppliers to be paying the real living wage within the next year, and also that stronger service user voice throughout that, and increase the amount of funding that we give through our grants and through our contracts to voluntary and community services. So thank you. If there's any questions, I'm happy to take them, or to expand more broadly on some of our work, or our work with Michael Marmot's team as well.
I'll mute myself there, the rookie error. Thank you so much. That's been really fascinating. We've already got someone wanting to ask a question, so I'll come to you first, Lizzie, and then I'll go to the questions in the chat.
Yeah, I was really interested to hear about the social value champions. I'd like if you could explain a little bit more about how they are involved, because it can be such a daunting process, the tendering process, and how do you incorporate social value champions into that process?
Yeah, thanks, Lizzie. So we're lucky enough that we've got quite a strong tradition of service user engagement. So we asked some of our sort of service user networks was it's not sound like the most exciting question, is anyone interested in contracting? But was anyone, some people's backgrounds were in that world or were interested. So those people step forward, we pay them for their time. So we pay them at a kind of NHS level pay. And they've had training from the procurement and contracting team, and then they sort of follow a process throughout. So it's part as well of them increasing their skills and confidence in getting back into the workforce, which is another piece of work we're doing around service users back into the workforce. And some of that is giving them opportunities within ELF just to step back in. Maybe it's just half an hour every couple of months, or it's a bit more than that. And then what we've seen is people feel more confident and then go for bigger jobs as well. So it's kind of a win-win for that one in particular. But I can send more details on how that works and how the kind of service user engagement works as well.
Please do, Angela, and thank you for that response. I'm going to go to Susan now.
Thanks very much. A couple of questions. I stuck one in the chat actually, which is really just about how you're measuring social value. Is that what the strategy, I forgot what you've said it was called now, but that organisation was doing for you? Because I know from personal experience in a different role that that can be quite tricky to do, because people talk about social value and then they might be talking about social value that they're actually adding to a very different community somewhere else in the UK. So it's not necessarily about providing apprenticeships locally. It might be, somewhere else, and also how they count it. They might just be kind of talking about their overall apprenticeship program rather than actually adding on anything additional. So really interested to hear how you do that. Second question, sorry, is around things like the real living wage. Are you also requiring people to make sure that their subcontractors are also paying it? So for instance, the cleaning staff and the catering staff, because those are the people who most often are not being paid the real living wage. And if you are, do you give them time to meet that contractual or get out of existing contractual arrangements? I'll stop there. I could ask lots more, but thank you. It's really interesting.
No, thanks, Susan. And I'm public health. I'm not a contract expert, so I'll try and answer it as best I can from my perspective. So the measuring one is really interesting, and I think as the more I've got involved in this work, if you're not careful, there's all those unintended consequences, isn't there, where you think you're doing good over here, but actually it's causing problems over there. And it's certainly, I think one of the first worries we had is that we were, by adding all of this in, we were playing into the hands of those big corporates that could say, yes, we've got a huge apprenticeship scheme that covers the whole of it. So we've tried with the work with the Health Foundation funded work with the strategy unit, it was to really untangle that and the toolkit to really get into some of that detail that was helpful for contractors, and try and simplify it as well and make the playing field. It's not an equal playing field. It's meant to be that those smaller organizations that were doing more locally almost got to help up. So it's more of an equity than an equality approach to it. So we will handhold and ask for slightly less from some of those community groups than we would expect from the huge multinational contractors. So there's some complexity and sophistication to that. And in terms of the measuring, then again, it's where the procurement team who have really got on board with this and run with this will really drill down and ask for specifics and ask for, where is the increase in apprenticeships in these definitive areas rather than a general increase, and that we also follow up every year with them, so that we keep doing these audits. And if they don't reply to the audits, we contact them about saying that's kind of out of contract if you don't reply. And we expect to see the increase, if that makes sense. But again, I can send you some more of the detail from the contracting team. But there's one thing awarding the contract, there's then evaluating the contract, isn't there? So we've put a bit more resource into the contract evaluation team, for want of a better word, on the contracts team, to support the social value work. The real living wage is a trickier one. So yes, so the new facilities management program, they are being paid the real living wage, which they weren't before. as well as having other NHS terms and conditions built into those contracts. And I'm just reminded of the fact that someone said, oh, isn't that amazing? And like, aren't we great? And I said, no, that's just, we're the NHS. That's just basic kind of, if we look at hierarchy of needs and basic needs, we shouldn't be congratulating ourselves on the fact that we're paying the real living wage. We have asked all of the contractors, as well as their direct payments that they have to pay the real living wage, we have asked them to talk to their subsidiaries, and a couple have come back saying that's going to cost us XYZ. So we're just trying to work out and talking to other trusts who've done it, will that come back to bite us, and that they'll then expect us to give the ward a much more expensive contract because we expect them to pay the real living wage. So I think we're just beginning to try and unpick how wide the ripples go on the real living wage, but certainly all our direct contractors are 61% are paying the real living wage, and we're just going out to audit again, but we've set a target for the next year that all of them will be paying it. So any new contract that we've done is the real living wage.
I think that links nicely into the next question actually that's been posted in the chat from Liam Coleman, who says, have you found any challenge between targeting against your objectives and achieving cost savings and value for money, given the current against the backdrop of the current significant cost saving challenges? So it's like, how do you balance that up?
Yeah, Liam, that's that is what we're balancing with, and I think we did quite an in-depth study of the kind of cost benefit of the previous soft FM contract, certainly where we start to unpick the fact that sickness absence wasn't paid for the first few days. And then if we look at the cost of managing an outbreak in one of our wards, then it dwarfs it. So we have tried to draw back and take a more broader public health approach to some of this. So when it can get down to, well, this contract's slightly more expensive, where we've been able to, we've pulled on evidence and been able to pull that together quite quickly. So one of the benefits of having public health registrars in the organisation is they can quickly do a kind of evidence summary or a quick cost benefit to actually say, but in the long term, it's worth it. And because our service users and local communities helped us develop the social values and they expect to see them, then there is a sense of accountability against it. And I've been really keen with the trust that we hold ourselves to account on where we're improving population health as much as we do on, are our wards safe? Are we managing our service users' mental health and physical health really effectively? Are we balancing the books? So it's to get that parity of improving population health, and you wouldn't start to pay off that against human resources. Whereas sometimes with some of the population health work, it's easy to say, well, that's not an essential core service, we can drop that. Because we're trying to say, no, we're part of the system to improve health, reduce health inequalities. We should hold ourselves to account as much as we would against anything else. And I think it goes into what Shell was saying about that short-term funding. So many of our improving population health or public health projects in the NHS are little grants, short-term funding, and yet we talk about our role in increasing, tackling inequalities. And I think the danger with that is you wouldn't build your whole IT system on short-term grants. So why would you build a 3 or 4 year program of work to address inequalities on it? So I think there is something about business as usual in that. So we try and put some of those increases in contracting against some of those broader public health measures. And sometimes it lands and it goes through, and other times it doesn't. I don't know if that's answered your question. I might have gone off on a public health rant there.
I think that's a really, really helpful and interesting and important response actually to some of this stuff, which is, actually longer term, there are costs to not doing this than doing it. I think that there is, I'm just going to scroll back up the questions. Yes, Wayne Daly has asked a question about whether you found any resistance from your finance department in terms of doing any of this, and particularly allocating funding to the third sector, any legal challenges in procurement process and things like that.
So finance are part of, obviously, key part of the conversation, but because as the board, they adopted the 6 areas of improving population health, and procurement, this work was one of them. The board has signed up to that, including the director of finance. And where we've done this work, we have always included, obviously, the cost element as well as anything else, putting a SWOT analysis on it or whatever. So they've bought in as a check and balance. And I think sorry, what was the second part of the question? Because it's finance.
So it was the legal challenges really around
Yes,
that.
so we have set up a subsidiary of ELFT, which is an umbrella organisation for voluntary and community groups. So it's a not-for-profit legal subsidiary. So they're an umbrella group called Compass, who manage and support voluntary and community services. So I think, I'm not a lawyer or a finance person, but I think it's kind of managed that way. So we can give Compass the funding, and they then distribute it to a VCS group. So it's like a wholly owned subsidiary of ELF. So I think that's quite a useful mechanism to think about in terms of how you engage with VCS groups. And we've increased the funding this year to VCS groups, and they're delivering services for us. So it's the grants or the contracts are linked to our service objectives, and they're a good way of employing local people. They're a good way of supporting local businesses. They're a good way of supporting those VCS groups to either stand up further, or if they don't want to, they don't have to. And I've been involved with those groups around helping them understand what are health inequalities, what's the language that might be being used in bids from a public health perspective or from an ICS perspective. So we've kind of supported them in other ways around training them around finance, training them around how to write a really good bid, how to show that they're reducing inequalities, or what's the population health need that they're looking at. So we've kind of built a little support network around them to help them to move up and to get increased funding if that's what they want to do, and to deliver some of our services.
Thank you so much, Angela. I think that it would be really great if I could ask you to do the same with Angela's presentation as we have with the others, and really focus on what your one takeaway is from Angela's presentation. I think from my perspective, it feels like that capacity building piece really comes through. How do we support others to be able to take on those contracts and really build their capacity and the sustainability? We've just got a little bit of time. I must have been very vicious in my chairing because we're actually running we're running a little bit ahead of time. So I'm just going to ask one question of each of our presenters today before we then kind of move into the closing bit of this webinar. So I'm going to come to you each in turn and ask you to reflect back your one piece of advice to others in your shoes. So trying to get off the ground the kind of initiatives that you're getting off the ground, because I think that what we've got here is a really big group of people who are really interested in what you're doing. So what's your takeaway for them? What's the thing that you would really want them to know that you wish you'd known at the beginning of embarking on your piece of work? So I'm going to come to you first, Lucy, if that's okay.
Sorry, Saffron, just took me a moment to find unmute. Thank you. So interestingly, I think that someone put this as their takeaway kind of immediately after my presentation, and it sounds kind of obvious, but I think it is all about relationships and trust. And I definitely don't think we'd be able to do anything that we're doing without that. So sorry for an obvious answer, but I just think it's so important.
I think obvious is good. Sometimes I think we try and overcomplicate things, and sometimes the clear, most straightforward, obvious answer is often the one that is the most important one. Thank you for that, Lucy. Shell, I'm going to come to you.
So I'm not going to give you one answer. I'm going to give you three essential ingredients. So 3 essential ingredients, I would say, are build with them and not for them. So co-design services or products with the people you're wanting to engage with. The second ingredient is don't just look to address barriers, but look to address the root cause to make the sustainable changes that you wish to seek. And thirdly, look at enhancing existing initiatives and connecting in with them to optimise reach and impact. So we avoid duplication and we amplify and accelerate.
Thank you so much. That's really, really sage advice there. And Angela, if I can come to you.
I think so. I think building on what Michelle's just said, I think that the service user patient engagement and getting them involved and getting them to set the ambitions and the targets always gives you something to fall back on when people challenge it, in that it's been developed by people where it's really going to impact rather than a few of us NHS people in a room. So that's got me out of a lot of arguments and discussions when I've said, but we asked people, this is what they said they wanted us to achieve. We need to find a way to achieve it.
Thank you so much. I think that kind of gets beyond that brings together both the evidence case, i.e. these are the people you are trying to support, but also brings to bear a really important moral case as well, which is it can only be better to be working with and through the people who your service is there to serve. I think that it's been an absolutely fascinating set of presentations. I think that I've learned so much in the last hour and 20 minutes or so in terms of these different dimensions of being an anchor institution. So Lucy, the work that you've done in your community about really, putting physical places into the community and then really bringing people in and supporting them, that is the genuine, that's a genuine hub and a genuine anchor in your community. And I think that speaks so much to both the anchor agenda, but also the place agenda. I think that what I take away from Shell's initiative is that real sense of actually good employment, and people being in good employment actually is a route to better health, and also looking at individuals who are seeking employment and finding it really hard and treating the whole person just as you would if it's what we aspire to in healthcare, isn't it? Holistically being able to treat the whole person, and that feels so important. And then just reiterating that point on the social value piece, which is not only is it kind of with and through patients that you're developing these approaches, but you're building genuine capacity within local communities and boosting local economies. So for me, that feels like there's such important elements of the anchor approach. And I think really important, I always slip into the terminology of anchor institution, but it isn't about institutions, is it? It's about services, it's about communities, it's about the people who will benefit from this. And it does feel incredibly compelling, particularly that I think that end-to-end piece in terms of it's not just about tackling health inequalities that are there now, but it's the generational piece, because we know that people move out of those cycles of deprivation once they get into employment, and we can help to support that through the anchor approach. I think that this has been such a fascinating conversation. As you know, we have been recording it, so if there are any bits that you want to watch back, you can do that. Also, we will ask you to fill out the evaluation that will be sent to you. It's really, really important. Well, you can actually scan the QR code. This is so modern. I'm not used to this modern approach, but you can scan the QR code and it will take you to the evaluation form. You'll also have a link in the chat. And we have gathered from you so much really helpful feedback and information in terms of your comments on today's presentations and what you have taken away. You'll find this presentation on our website, and it will also be circulated to you. And if there are any unanswered questions on the chat, I don't think there were many. I think we got through most of them, but if they were, then we will, of course, send round the answers to those as part of the post-event resources. And I know that our speakers have also promised additional resources, so it'd be really great to have those so that we can share them with you. Thank you to all three of our speakers, to Angela, to Shell and to Lucy. You've been really great and really open and honest and informative in what you've given us. And also thank you to you all for offering your comments and asking the questions, because it's that interaction that really helps to tease out some of the bits we might not have come to light. And I think what does stay with me is Shell's point around actually, funding for things isn't the holy grail, because if you make something sustainable, then you really get to the heart of the systemic issues and you can tackle them yourself, and then maybe the funding follows that. And I think that is perhaps something that will be heartening for all of us when we start to think about different approaches to tackling health inequalities and the role of anchors within that. So thank you all. I'm going to give you the gift of a few minutes time because we have finished a little bit early, but that was really great. Thank you, everybody.